And as Gianluigi says, we're going to kick off with quite a common finding, which is ventriculomegaly, which is not only common, but it's also can be quite difficult in the counseling for ventriculomegaly because it is a lot of issues that surround it. And what we're going to do is take a step-by-step approach and talk through all the different issues surrounding ventriculomegaly. What I'm going to be talking about is talking about enlargement of the lateral ventricles. I'm going to stay away from talking about third and fourth ventricular enlargement because they fall mainly into the talks that you're going to be hearing later on. And mainly also I want to talk about isolated ventriculomegaly rather than ventriculomegaly that's associated with other abnormalities. And again, the reason for that is that when other abnormalities are present, it is those abnormalities that will dictate the outcome rather than ventriculomegaly itself. And in a way, it's isolated ventriculomegaly that is the most difficult in terms of counseling. Just very quickly, and I know this is the advanced course, so I'm not going to spend much time on standard examinations for the measurement of the lateral ventricle. These are from the ISWALK guidelines. The ventricles are measured at the level of the atrium, and you can see that the calipers are placed at the level of the glomus, of the choroid plexus there. And they're placed just on the inside of the echoes that are generated by the ventricular walls. So not on the ventricular wall, not outside the ventricular wall, but just on the inside. And the standard method that almost all of us will be examining these is in this view, which is kind of the biparietal diameter view, maybe just a tiny little bit higher if you're taking the transthalamic plane. But you can examine the ventricles also in the coronal plane, like this. This is particularly important if you're doing a targeted neurosonogram in order to get that other dimension. And the advantages of taking the coronal view, of course, is that you can see both ventricles much more clearly. When you're taking this view, you're only seeing the most distal ventricle clearly, and the proximal ventricle is obscured by the shadow from the concave skull. And if you measure it like this, that's been shown to be very well correlated to MRI imaging, and this is a T2 weighted coronal image of that same fetus. But the standard examination, and if you're going to look into multiplanar neurosonography, which we'll talk a little bit about more later, you should really look also in the coronal view. The normal size of the fetal atria is very stable throughout gestation, which is often apparent when you see a fetus at 16 weeks. The ventricles seem bigger compared to the head, but that's because the size of the ventricles is roughly speaking about 7.5 millimeters, and that's more or less the same whether you're 16, 20, or 34 weeks. So they don't change a lot. And mild ventriculomegaly is generally defined and will be defined in this talk as an atrial width of 10 to 15 millimeters. And if you look through the papers, there's all sorts of definitions and all sorts of words bandied about. Some people talk about mild as being 10 to 12, otherwise call it borderline. Some people call borderline 9 to 11. Some people call mild 10 to 12 rather than 10 to 15, and then use moderate for 12 to 15. And that actually leads to quite a lot of confusion because no one's really said this is what mild is and this is what moderate is and this is what severe is. But for the purposes of this talk, and can I suggest that, perhaps it might be an idea to start sticking to a single terminology, mild ventriculomegaly, 10 to 15 millimeters. And the reason that there shouldn't necessarily be a different terminology is that the terminology should be outcome-based, and what I'll be showing you is that actually it doesn't matter if it's 11, 12, or 15 millimeters, the outcome within that group is very, very similar. 10 millimeters of a ventricle is the fourth standard deviation, and that means it's a pretty uncommon thing. Well, we know that we see it quite commonly, and how much the incidence is exactly is a little bit uncertain. It's about probably 0.5 to 1%. And unilateral ventriculomegaly is a little bit rarer. Not a lot of studies on unilateral ventriculomegaly because it's only recently with very good ultrasound machines that you can routinely examine both sides in every fetus. and it's running at about 0.07%. If you look at the White Journal, we published last year a paper on isolated mild ventriculomegaly, and most of this talk is based around those concepts. And what we wanted to do in this paper is really review all the literature that was available in order to help us counsel our patients, and then we wrote it down so that hopefully it might help you counsel patients as well. And we reviewed over 500 papers on ventriculomegaly, 90 of which were relevant for the study, and 16 of which we included in giving us the various outcomes for this talk. So the first question is, you see a woman, routine clinic, and you see mild ventriculomegaly. You've had a look. There's nothing obviously otherwise wrong with the baby. Should that woman be referred to a tertiary center, or should she be followed up locally? And in my unit, I routinely see women who were seen at the local center at 20 weeks with ventriculomegaly, and then they were followed up locally at 28 weeks, and then again at 34 weeks, and then they're referred to me at 34 weeks because there's been a progression of the ventriculomegaly, or because now they've seen something else that they hadn't seen before. That makes my life actually really very difficult, because it limits very much as to what I can do as a tertiary level specialist for that person. And I suggest that it is worth referring patients for a detailed tertiary level scan, because although some abnormalities are very easy to see, such as absence here of the cerebellar vermis, this is a cerebellum, you can see, and a big black space in the middle, or spina bifida, which can be easy to see, more or less, sometimes depending on the position of the baby. Other things can be a little bit more subtle. So here, for instance, on this image, you have a parasagittal view of the baby, which is showing lack of sulcation and circumvolution of the brain. And when we did an MRI on this baby, we saw pachygyria, which was due to CMV. So this was a baby that was originally thought to have isolated ventriculomegaly, and then this is what we found. Absence of the corpus callosum can be more or less difficult to see, and you have a talk on that later on today. And this is a case of holoprosencephaly, which should be very easy to see, except in this lady, there was multiple fibroids, and the woman was actually very large as well, and it was very difficult to get clear views of the head, especially as it was breech, and it was impossible to do a transvaginal ultrasound scan. So, in our opinion, and this is an opinion only, a lot of this is opinion because we don't have data to suggest that the outcome is any better if a woman is referred to a tertiary level center. We feel that we owe it to the patients to have a detailed scan by a team that is routinely involved in doing detailed neurosonography. So if you just stick with neurosonography, the next question is, should we do a transvaginal scan? And a lot of people are extremely expert at transvaginal ultrasound scan. I'm not one of them because I work in England, and in England doing transvaginal ultrasound scans is very difficult because our patients in England are quite prudish, unlike a lot of patients in other countries. But again, it's the same point really. Some malformations that are commonly associated with ventriculomegaly can be difficult to see in the standard planes. And therefore, you need to do a multiplanar neurosonogram in order to look for other features, in order to look, for example, for the corpus callosum in this coronal scan, and here in this sagittal scan. Can you see that double line there, which is a nice exhibition of that? Or if you look transvaginally, you can see very nicely some of the sulcations and circumvolutions, or in the absence of that, very smooth brain in this parasagittal view of lissencephaly. And these are pictures from various people, including Gianluigi's papers. So in our view, detailed multiplanar neurosonogram is recommended for those reasons. Now, whether you do this transvaginally or whether you can obtain a good multiplanar neurosonogram transabdominally depends on the fetal position and the preference of the woman and your expertise. But a multiplanar neurosonogram should be done. The other thing that will depend on this is whether you do a lot of MRI in your unit or not. And this is the next question, whether we should consider MRI. So this is an MRI scan of a fetus with mild ventriculomegaly. This is a normal MRI scan here, showing really very nicely all the different structures. And if you contrast that to this baby, which is of a similar gestational age, showing this, can you see very striking, this extremely smooth surface of the brain compared to there? And this is a lissencephaly type 1. And surprisingly, perhaps, on ultrasound, it can be quite difficult to see some of these sulcations, gyrations of the brain, and MRI is a very useful adjunct to that. Now, of course, one of the limitations that you need to think about is the gestational age at which you scan the patient, because the processes of folding of the brain continue well into the third trimester. And so when you don't see something on ultrasound, it can either be because you've missed it, or it can be because it hasn't occurred yet. So the gyrations and the folding of the brain continue into the third trimester, and therefore a third trimester scan might be the most useful in terms of ensuring normal brain development on MRI. This is a collection of papers looking at what additional information was given by MRI over and above the ultrasound scan, and you can see that it's roughly about 41 out of 500, so 8% of cases. One issue with MRI, this is extremely important, is that the person who's going to do your MRI and who's going to interpret your MRI must be someone who is used to looking at fetal MRI scans. And the reason for that is that the brain in the fetus looks very different from the brain of even in the neonate. And it's very easy to misinterpret MRI scans as being showing immaturity of brain development if that person is not really used to or good at looking at fetal ultrasounds, fetal MRI scans. There are also other issues such as fetal movements, etc. So what I want you to go away with is that MRI isn't going to solve our problems, but that MRI is a complementary investigation to ultrasound scan. And if you talk to your neuroradiologist, you'll find that because ultrasound's been around a lot longer than MRI has, our normal ranges, for example, for the cerebellar diameter or even for the ventricles, are much better established on ultrasound charts than they are on MRI charts. So there's a massive place for ultrasound. MRI complements that. And the particular advantage of fetal brain MR is that it allows analysis of the gyration, which is best done in the third trimester. At St. George's, we're quite liberal with MRI, to the chagrin of our neuroradiologists, because, we keep them very busy, in that we quite frequently do 2 MRI scans. We do a multiplanar neurosonography at diagnosis at 20, 21, 22 weeks. And if there is any suspicion of any inadequate views at that stage, then we do an MRI at that stage. And then we repeat that MRI unless everything looks otherwise completely normal in the third trimester. That brings me to serial antenatal examinations and whether a serial examination needs to be arranged. So most of us follow up cases with ventriculomegaly. And the reason for that is that a proportion of ventriculomegalies which look just mild and isolated subsequently progress, and this is the worst thing that you can always think of when you see a woman who comes at 28 weeks with a follow-up for mild ventriculomegaly. This is what we all dread, seeing a large progression. And if you look at the 13 studies that are in the literature that look at progression, in about 16% of cases there is progression of the ventriculomegaly from mild to severe. And this is important because the subgroup of fetuses where there is progression of the ventriculomegaly have a much higher incidence of neurodevelopmental delay than the ones that stay stable or the ones that regress. So the risk of developmental delay, based on about 10 studies, as you'll see, in ventriculomegaly that's mild and that stays stable is about 5%, perhaps 10% if you include some of the case control studies, whereas in progression, the incidence is much higher, at least 16% and perhaps as high as 30%, depending on which studies you look at. The other thing to think about serial antenatal examinations, and I keep coming back to this thing, is that one thing is looking for progression and one thing is looking for structures that you were not able to examine very well because the baby was too small, because you got an inadequate view. But remember that the brain normally continues to change throughout gestation. So although you can do an echocardiogram, and if the heart looks normal at 20 weeks structurally and everything looks completely normal, it's going to be normal. The same is not true for the brain. Just because the brain looks normal at 22 weeks, it looks like that at 22 weeks. And that's what it's supposed to look at, like at 22 weeks. What you can't do is predict whether it's going to continue to form normally. Now, the risk of that happening is extremely small if there are no other brain abnormalities at 22 weeks. But in cases of ventriculomegaly, that risk goes up. And the landmarks for normal development change as pregnancy changes. So the central sulcus, which is that arrow number 2 there, which appears at about 20 weeks. And you can see that the precentral sulcus, which is almost impossible to see there, becomes much more apparent just 4 weeks later, at which time also the postcentral sulcus becomes visible, which is that arrow number 3. So this sulcation pattern of the brain, which is really pretty smooth at 20 weeks, starts appearing at about 24 weeks and continues into the third trimester. And you'll all have noticed this little bulge here, which is a Sylvian fissure, which you can see on every scan that you do. It's a shallow little indenting. It's a Sylvian fissure. And at 20 weeks, it's kind of shallow and flat, looks like a lens, and that's normal. But if you get that same picture at 28 weeks, then that's not normal, because at 28 weeks, it's supposed to look much bigger and much more square like that. So a progressive sulcation pattern in the brain, which is something that we can look for. So apart from progression, another very important question is, what is the risk that when you see a baby and you think that the ventriculomegaly is isolated, that ventriculomegaly is not in fact isolated? Am I making sense? So you see a baby, you've done a scan, you think everything looks otherwise normal. What is the risk of there being another cerebral or extracerebral abnormality that you haven't seen? The risk of that is about 10 to 15% based on 16 studies. And whether it is truly isolated or not depends on the antenatal protocol that you use. And I'm talking here about isolated at the time of the routine anomaly scan. Okay? There are some papers that report what they call truly isolated, which is at the neonatal examination, they re-examine the baby and they exclude any other features. But that's not very useful for us when we counsel our patients, because we counsel our patients at 20 weeks. So at 20 weeks, everything looks normal. Congratulations, your baby has ventriculomegaly, mild, and it's completely isolated. Actually, in 13% of patients, that will not turn out to be the case. In some studies where multiplanar transvaginal scans are done and MRI is done almost on a routine basis, there were no cases of false negative diagnosis. So how isolated or not it's going to be is going to depend on how hard you look for the changes. Okay, so there's 2 cases here. Very mild ventriculomegaly. And can I just get your attention to that little area there? Can you see that? It doesn't look quite right, does it? It doesn't quite fill the space that it ought to be filling somehow. And this is a case of... and then if you look at the MRI, again, you can see thinning of the cortex, and you can see this abnormal space between the brain and the skull. Obviously, the ventriculomegaly is there as well. This is a case of cytomegalovirus infection. Which brings me to the next question, whether we should be doing CMV and toxoplasmosis testing in cases of ventriculomegaly. And the answer is probably yes. And the reason is that this is a non-invasive test. It's not expensive. You can take it from the mother. You get the results fairly quickly. And the ultrasound findings in CMV can be really very subtle. And what, again, want to bring your attention to is a slight echogenicity around the edges here. Can you see that? And this, seeing the outside of the brain, which is never very good when you're looking at ventriculomegaly, seeing that space there. Again, a little bit of echogenicity there and around the edges. So that echogenicity that you can see in CMV is quite characteristic. The other thing that you can see here is a very smooth surface of the brain. These are some other subtle findings. These are from a paper from Gibor. You can see little synecdoche inside the ventricular margins and calcifications. Again, little calcified foci here and there. Here, this is a very subtle finding. Can you see that line there? Nice white line, and then you sort of lose that line. So there's some tissue protruding into the ventricular wall, which is just a destructive lesion, essentially. And again, generalized calcifications there. And all of these are on your handout, so you can have a look at them. So CMV and toxoplasmosis testing, easy to do. The next question is prenatal diagnosis. So the woman has isolated ventriculomegaly. Should we be talking about doing a test for Down syndrome? And the answer to the question is it depends. And it depends on whether the woman has had first trimester screening and what result that first trimester screening gave the woman. Because if the risk was extremely low, it may be that the isolated ventriculomegaly may not bring the risk up sufficiently. Obviously, you need to look very carefully for other features of Down syndrome. But if you put the risks together from all the studies, and this was done in Canada on a meta-analysis, the risk of Down syndrome based on idiopathic mild ventriculomegaly of an isolated nature gave a likelihood ratio of about 9. That means that if the woman's starting risk after first trimester screening was 1 in 900, after the finding of ventriculomegaly it becomes 9 in 900 or 1 in 100. And it's based on that you will make the decision of whether to karyotype or not. So likelihood ratio, isolated ventriculomegaly for Downs of 9. A lot of people talk about platelet alloantibodies and the risk of hemorrhage in the brain. Ventriculomegaly can be associated with intracranial hemorrhage, but in the main, it's pretty obvious. You get calcified areas within the brain, or obvious areas of hemorrhage, or obvious areas of calcification on the ventricular margins. And if you do an MRI scan, the MRI scan really will go quite a long way to exclude an intracranial hemorrhage in these babies. So most centers, and certainly in our centers, do not routinely perform platelet alloantibody testing on women with isolated ventriculomegaly, unless there are other features that don't look good, such as brightening within the ventricles. So, we've done a scan, we've done our karyotype, we've discussed the karyotype, the CMV, and everything else, and this is truly what we think isolated ventriculomegaly. How is my baby going to be? Well, neurodevelopmental delay in these babies is in the region of 10%. So, or turning it on its head, about 90% will have a normal neurodevelopmental outcome in infancy. And there's two really important questions here. The first is, well, is this actually any different from the general population? And the answer to that question is it's difficult to tell you the answer to that question, because how common mild or moderate neurodevelopmental delay is in the general population is not terribly clear, and there are not large or very good studies that tell us that. And whether or not isolated ventriculomegaly is associated with an increased frequency is a little bit unknown. There's certainly not a large difference. If there is a difference, it's quite mild. So that's the first question. The second question is, well, what is neurodevelopmental delay and does it actually matter? Or in other words, how frequently does neurodevelopmental delay progress to handicap, which is really what we're concerned about? Because the parents aren't necessarily worried about whether the child will have slightly delayed milestones for a few during infancy, rather whether there will be long-term handicap. And not all babies that have neurodevelopmental delay will go on to have handicap. Factors that influence the prognosis, very quickly. A lot of people always talk about male versus female in ventriculomegaly. If there is a slight difference if you add up all the studies, but actually it is not significant in that the confidence intervals of this risk ratio cross one. So it doesn't seem to matter really if the fetus is male or female in terms of the neurodevelopmental delay. Factors influencing the prognosis. Another factor is the size of the atria. And on your CD, there's a paper which we published on this. And I want to bring your attention that in Table 5, there was an error. In addition to that, there's been 2 further papers studied on this issue. Melchiora, which was published at the end of last year. And this is an important paper, which I'll discuss a little bit more detail, by Levine, which is currently on the accepted. You can click through the ISWOG website, if you remember, and get to the accepted papers. And this is an accepted paper which will be appearing in the White Journal. If you put all the studies together, you find that the risk ratio of an atrial width of 12 to 15 compared to 10 to 12 is just significant, with a risk ratio of 2. Certainly not a high risk ratio, not a good predictor of neurological outcome, but it appears that when the atria are just above 12 rather than just below 12, there may be a slight increase in risk. And this is different from the conclusion in the paper that you have, so I'm just bringing your attention to it. Nevertheless, it is not a major change in risk, as you can see. This is the paper by Levine et al. I'll just quickly show you that this was a large study. There's 140 cases. It was a prospective study. Importantly, babies had a fetal MRI. And unlike many other studies, they did objective assessment of neurological outcome using mental developmental indices, psychomotor developmental indices, and the Vineland behavioral score. And they did formal follow-up visits at 6 months, a year, and 2 years. And they had 143 infants with complete follow-up postnatally. So this is a very large series, certainly the largest series. And in that paper, the conclusion was that the magnitude of differences didn't vary among the groups between less or greater than 12 millimeters. And adjusting for covariates or the presence of neurological abnormalities was not significant again. So if you're interested in ventriculomegaly, this is an important paper to read. And they conclude again that prenatal measures of atrial width may be of limited prognostic utility. So in ventriculomegaly, the size of the ventricles is a little sign that tells you this baby has ventriculomegaly. The actual size matters less than what is the cause of it. Is there a coexisting abnormality, and is it going to progress? So we've talked about progression already. 16% of cases progress, and false negative diagnosis, the risk of a false negative diagnosis of 13%. These are the factors that most affect outcome. Just a few words about unilateral ventriculomegaly, and as I alluded to before, few studies have looked systematically at whether ventricles are enlarged unilaterally or bilaterally. And there's a difference between unilateral ventriculomegaly, which means one ventricle is enlarged and the other is normal, or asymmetrical bilateral ventriculomegaly, where both ventricles are enlarged and one is enlarged more than the other, and by more we mean more than 2 millimeters. Nevertheless, even isolated unilateral ventriculomegaly doesn't seem to be a benign phenomenon, in that it is associated with neurodevelopmental delay in the same way as bilateral is. Asymmetrical bilateral ventriculomegaly appears to carry a worse prognosis than symmetrical bilateral ventriculomegaly, and that may be because of an underlying destructive lesion on one side of the brain than the other. Finally, we come to postnatal management. Generally, the agreement is that postnatal assessment should be performed by a pediatrician, certainly at birth, in order to exclude any other obvious abnormalities that were missed on ultrasound or through the antenatal protocol. And further follow-up should be based according to this diagnosis at birth. Some people have advocated long-term postnatal follow-up and MRI. And there's no evidence to suggest that this is a fantastic thing to do. Certainly, it may not cause any harm. And if you do pick up neurodevelopmental delay, early intervention, we know, is of benefit in bringing this baby's development forward. However, there's a counter side of it, in that if we've worried a woman about an isolated mild ventriculomegaly throughout her pregnancy, all the tests have been normal, the baby looks normal after birth, how long should we continue to medicalize that person's life, which is going to be almost certainly just a normal variant. So, that's all about ventriculomegaly. It affects that many pregnancies. Imaging should be optimal. Imaging should be in a tertiary center or in a center with expertise at clear and careful imaging of the brain. Multiplanar imaging should be done. Whether you do it transvaginally or transabdominally is up to you. Certainly with transvaginal images you get much better views. An MRI should be performed certainly in the third trimester, and increasingly is performed also at diagnosis. Serial assessments should be undertaken because 16% progress. You should do a CMV and toxoscreen. You should discuss invasive prenatal diagnosis. Platelet alloantibodies may be of limited use unless there are other signs of intraventricular hemorrhage. The risk of a false negative diagnosis should always be taken into account. So in your counseling, when you talk to the woman and say, this is isolated ventriculomegaly, you must leave the window open that there is a small chance of about 10 to 13% that their ventriculomegaly is not in fact isolated, and there are things that we haven't seen, either because we haven't been able to image them now, or because they have not yet appeared in the development of the brain. Neurodevelopmental delay occurs in 11% of the population of ventriculomegaly babies, and the risks for this are the cause, unrecognized coexisting anomalies, progression, and to a smaller degree, atrial width. And the question of postnatal follow-up is open. Just the final slide. Please bear in mind that these studies are observational studies. The majority of them are retrospective. The majority of them involve 10, 12, 16 patients. It's difficult to put the studies together, which is actually what we've done, but it is difficult to compare them because a lot of them have big differences in antenatal protocols. So my isolated ventriculomegaly may be different to Gianluigi's isolated ventriculomegaly. I do a transabdominal scan. Gianluigi does, transvaginal ultrasound scans and all sorts of dimensions. And the fact that, can we compare our data is questionable to some degree. There are wide ranges of gestational age at assessment. Some are tertiary level center studies and some are not. A lot of papers have assessed only the distal hemisphere rather than the proximal hemisphere. There's a high percentage of cases lost to follow-up in a lot of these papers. and there's a lack of distinction of the severity of neurodevelopmental delay. It's called neurodevelopmental delay or no neurodevelopmental delay. Well, what parents want to know is how much delay is it going to be? Almost all the papers have no control groups. There's a wide range of children. And most importantly, perhaps, apart from the Levine paper and a few notable other exceptions, most follow-up, neurodevelopmental follow-up, involves picking up the phone and calling the parents and saying, is your baby developing normally? Very few papers have objective long-term follow-up. And as I say, there are some notable exceptions to that. Thank you very much.